Well, finally, welcome. We thought we had a technical issue, and apparently not. So we're going to get started here. I want to welcome everybody to the CortiCare webinar series, which presents topics related to EEG and neurodiagnostics, patient care management, research, and future applications. A few technical notes before we get started. In the webinar space, there is a question and answer area. You can log in your questions during the presentation, and at the end of the presentation, time permitting, we will address them. The system also has a file that you can download. It's a white paper on continuous EEG in the ICU that may be relevant. I should note that we have future webinars coming up. The next one will be March 25th. There will be an invite sent out, but if you have selected to be automatically notified for future webinars, you'll get that invite. And it's Dr. Heba Haider from Emory University School of Medicine, and she'll be talking on the topic of epilepsy care in the time of COVID, which is timely. Also timely is today's topic of continuous EEG in the ICU and outcomes. With a growing use of EEG monitoring in critically ill patients, a question of its impact on the treatment and outcomes of its use is a natural question. After all, it's a resource-intensive technology, and its use should be managed by appropriate guidelines. Presenting on the topic is Dr. Zafar, a neurointensivist and boarded clinical neurophysiologist practicing at Massachusetts General Hospital in Boston, where she is Associate Medical Director of the Neuroscience ICU and is Director of the MGH Brigham Women's Hospital Harvard Neurocritical Care Training Fellowship. She completed her residency at Baylor in Houston, Texas, followed by fellowships in neurocritical care and clinical neurophysiology. She devotes her time in the neurosciences ICU, but her research includes interests including critical care EEG monitoring, seizures in ICU, and most appropriately, post-ICU discharge health outcomes. So I'm pleased and honored to bring Dr. Zafar onto the screen, and she will begin her presentation.
Thank you for having me here. I'm excited to be here and to discuss this important topic with you. So without further ado, what I will be talking about is critical care EEG monitoring and relation of monitoring to outcomes. There you go. I have no disclosures related to this talk. So the objectives of this talk are first and foremost to review the indications for continuous EEG monitoring, particularly reviewing the American Clinical Neurophysiology consensus recommendations around EEG monitoring. I will then talk a little bit about the common ICU EEG patterns that we see and their prognostic significance. And then to end, I will focus a little bit on the evidence that we have around EEG monitoring and whether monitoring itself impacts outcomes or not. So looking into the trends of continuous EEG monitoring, just as Jeff had mentioned, there has been an increase in continuous EEG utilization. This figure here is a study out of the nationwide inpatient sample that shows over a period of a decade, there was a 10-fold increase in the use of continuous EEG monitoring. And this was not only for patients with seizures or status epilepticus, but also in other acute brain injury patients and particularly in patients with altered mental status in the critical care setting. So of course, with the increase in continuous EEG utilization, there has been a greater interest in what are the appropriate indications and how this monitoring impacts outcomes in patients. And so to begin with, I'll start with reviewing the most common indications for continuous EEG monitoring. So these are taken from the consensus recommendations of the American Clinical Neurophysiology Society. And they recommend continuous EEG monitoring in patients with persistent altered mental status after generalized convulsive status epilepticus. So in general, patients who present with generalized convulsive status have improvement in their mental status within 30 minutes to an hour of presentation. And if patients are persistently altered, that raises concern for subclinical or non-convulsive seizures and is a strong recommendation for continuous EEG monitoring. Other recommendations per the ACNS include patients who have supratentorial brain injury and have altered mental status, particularly altered mental status that is out of proportion to the severity of injury. So if a patient presents with a small hemorrhage, but their exam, they're more altered, or they have weakness or deficits that seem to be out of proportion to their level of injury, that should be a consideration for continuous EEG monitoring. And then finally, patients who present with altered or fluctuating mental status in the absence of an acute brain injury. So this includes patients with sepsis-related encephalopathy, liver failure patients in whom we should consider EEG monitoring. Additional indications include patients who need paralysis and are at high risk for seizures. So this would include patients who may have a large underlying stroke or acute brain injury, but require paralysis, for example, for ARDS management. And one should consider EEG monitoring in these patients. Patients who require pharmacologic sedation, monitoring depth of sedation can be done with continuous EEG, particularly in patients who have refractory status and are receiving anesthetics, or patients who have refractory ICP and are on sedation. And then finally, another recommendation is for paroxysmal events. These could include abnormal motor movements, abnormal sensory phenomena that are concerning for seizures, and one should consider monitoring these patients, including particularly including video monitoring in these patients. Other indications for continuous EEG recommended by the ACNS, and these are more suggestions or considerations, not as strong recommendations or recommended as for the prior indications. These include prognostication. Many centers do use continuous EEG for prognostication, particularly in patients with hypoxic ischemic injury after cardiac arrest. And then another indication is for ischemia detection. More recently, continuous EEG has been used by certain centers for ischemia detection in subarachnoid hemorrhage patients. And this is another area where the ACNS suggests consideration of EEG monitoring for ischemia detection. Additional indications, so this is different from, so those are indications that have been recommended by the ACNS for adult and pediatric patients. There are separate recommendations also for neonatal EEG, and I wanted to briefly touch upon some of the additional indications to think of. And these include neonates who are at a high risk for electrographic seizures, for example, those who have inborn errors of metabolism or perinatal stroke, neonates with acute encephalopathy. EEG there is a recommendation for considering EEG both for determining the severity of encephalopathy, but also for evaluation of background abnormalities in neonatal encephalopathies. And in this scenario, they have recommended considering either continuous or serial EEGs. However, with the caveat that sleep needs to be captured for assessment of these patients. And so having at least several hours of EEG would be helpful, and that can subsequently be followed by serial EEGs if deemed more appropriate. Moving from indications to other aspects of continuous EEG monitoring, this includes the frequency of interpretation as well as duration of monitoring. So per the ACNS guidelines, the optimal monitoring, of course, is continuous review of the record by EEG technologists and other trained personnel, which often depends upon the resources available. And then with regards to interpretation and generation of reports, this is recommended to be done at least twice a day, but more often, of course, if patients have active EEGs with non-convulsive seizures or non-convulsive status epilepticus, immediately after cardiac event, immediately after an event, so an event concerning for a seizure or other paroxysmal events. And then if we're monitoring for ischemia, then the recommendation is to provide interpretations more often, up to 3 times a day. And there is a very strong recommendation for concomitant video use for these patients, particularly patients in whom the EEG is being utilized for capturing paroxysmal events. So moving from the frequency of interpretation, the next essential aspect is the duration. And while the recommendation suggests 24 hours of monitoring, this can be varied depending on the underlying etiology, as well as the early EEG findings. So for the most common indication, which is post-generalized convulsive status epilepticus, studies have shown that up to half of non-convulsive seizures can be identified within the first 60 minutes. And essentially, most patients, up to 95% of patients that have non-convulsive seizures will be recognized within 24 hours. And so if the indication really is for assessing for non-convulsive seizures post-generalized status, 24 hours of monitoring should be considered. The initial EEG can also be helpful, particularly in patients with encephalopathy or in whom EEG is being done because the exam is out of proportion to what the imaging reveals. And there is data that shows that the early EEG findings, particularly the first 30 minutes to an hour, if there is a high burden or if there's presence of epileptiform discharges on early EEG monitoring, these are the patients that are at a high risk of having seizures. And so long EEG can and should be considered in these patients. And so, again, the duration of monitoring really depends on the underlying etiology, but in general, getting 24 hours of data would be the most high yield in patients who are undergoing continuous EEG monitoring. So moving from EEG monitoring, the logistics and indications, I'm going to switch gears a little bit now and talk about the common EEG patterns that we see. Again, with the decades of data that we're gathering and the increased use of continuous EEG, other than electrographic seizures, we are beginning to recognize more and more other periodic and rhythmic patterns that have now come to be known as the ictal-interictal continuous patterns. And they can be seen in up to half of critically ill patients. And common etiologies include, as I've listed just a few here, but patients with acute brain injury, hemorrhagic stroke, traumatic brain injury, CNS infections, and the non-acute brain injury patients, particularly sepsis-related encephalopathy patients, have a high risk of having seizures and other interictal patterns. And so these are the patients in whom we should be considering EEG monitoring. And because of the recognition of these patterns, there has been more and more interest in trying to understand the diagnostic and prognostic significance of these patterns in critically ill patients. And so there have been more and more studies that are being done to assess whether these patterns are associated with outcomes, what is the risk of seizures with these patterns, and what risk they carry in terms of functional outcomes. And so many studies have been done to assess this. There have been smaller studies, often using variable definitions of these patterns, as a result of which the American Clinical Neurophysiology Society proposed a nomenclature system for these patterns to sort of harmonize. And this is a nomenclature that is now used not only for research purposes, but also clinical purposes. And the nomenclature is comprised of a main term and then two main terms which characterize the region of the pattern and the chief pattern type. So the main terms, the pattern location can be characterized as generalized, lateralized, bilateral independent, unilateral independent, which means patterns in the same hemisphere but occupying different territories or occurring at different frequencies, and multifocal. And the chief rhythmic patterns they can be periodic patterns, they can be rhythmic delta activity or spike and wave patterns. And to classify as one of these patterns, 6 cycles are required. I'm going to go through just a few examples. So this is an example of a bipolar montage, left frontotemporal, right temporal, left parasagittal, right parasagittal. And here over the right, we see these sharp waves that are occurring about once every other second. And this is an example of lateralized periodic discharges. Here is another bipolar montage. This is left versus right parasagittal. And we can see these sharp discharges that are occurring at about 1 hertz, one every second. But both the left and the right hemisphere seem to be running independently. The discharges don't line up. So this is an example of bilateral independent periodic discharges. Here is an example of generalized periodic discharges, where we, again, a double polar bipolar montage, left, left, and right. And we see these sharp waves that are running diffusely simultaneously, about 1 per second. This is an example of generalized periodic discharges. Here's an example of lateralized rhythmic delta activity, where over the right hemisphere we see rhythmic slowing, only over the right, and we don't see this over the left hemisphere. And finally, this is an example of generalized rhythmic delta activity, where there's diffuse slowing of the background, and towards the right you can see delta waves at about 1.5 to 2 hertz that are occurring rhythmically and diffusely throughout the background. When any of these patterns can occur spontaneously, or they can occur as a result of stimulation. When any of these patterns occur from or are stimulus induced, for example, examining the patient or suctioning the patient, we call them stimulus induced patterns or stimulus induced discharges. Very recently, the American Clinical Neurophysiology Society came up with a revised nomenclature that now has a formal definition of the ictal-interictal continuum. And essentially, there's been a lot of debate around patterns that don't clearly qualify as seizures and are not clearly interictal, how to define these and what their significance is. And so to assist with that, they came up with the definition of the ictal-interictal continuum, or the IIC. And they defined periodic discharges that are at a frequency of 1 to 2.5 hertz and last up to 10 seconds, or slower in frequency but have additional or plus modifiers or are fluctuating, or a lateralized rhythmic delta activity at a frequency of greater than 1 hertz, again lasting for 10 seconds, and then along with plus features and fluctuation, are considered IIC or ictal-interictal continuum patterns. There is also a qualifier that these patterns should not qualify as electrographic seizures or electrographic status epilepticus. And so this is helpful now as we interpret EEGs, as well as we do more research into trying to understand the diagnostic and prognostic significance of these patterns. So very quickly, just looking at some of the etiologies, as one can imagine, lateralized patterns, so lateralized periodic discharges or lateralized rhythmic delta activity occur more commonly with structural brain injuries, with acute ischemic strokes or hemorrhagic stroke, traumatic brain injury. Whereas the more generalized patterns, including generalized periodic discharges and generalized rhythmic delta activity, occur in more diffuse processes, such as acute toxic metabolic encephalopathies, sepsis, anoxic brain injury. Having said that, that's not a hard and fast rule. One can certainly see lateralized patterns in a more diffuse process and vice versa. These are just, the more common distribution of these patterns that we tend to see in the critical care setting. So the next question, of course, is what is the significance of these patterns? What is their relation to seizures? Do they result in secondary brain injury? And finally, how do they impact outcomes? And all of these questions are important in order to help and guide us in the best way to treat these patterns. And while there haven't been very many large studies that have been done to answer these questions, there have now been several smaller studies, either looking at smaller cohorts or smaller heterogeneous populations, to try and begin to answer some of the questions. And over the next few slides, I'll go over some of the data that we have around the relationship of these patterns with outcomes. To answer our first question, what is the risk of seizures in association with these patterns? And one of the largest studies that has come out was done by the Critical Care EEG Monitoring Research Consortium. And they looked at about 4,000 patients, and what they found was generalized rhythmic delta activity is not significantly associated with seizures. However, periodic discharges, whether they're lateralized or generalized, along with lateralized rhythmic delta activity, have a significant association with seizures. You're more likely to see seizures in these patients. And this risk actually increases as the frequency of these patterns increase. So as the frequency increases from 1 to 1.5 to 2 hertz, the risk for seizure increases. At the same time as the prevalence, so the more, the longer these patterns last, or the greater the percentage of an epoch occupied with these patterns, the greater is the risk for seizures in association with these patterns. So this is one of the largest data sets that we have that shows us the relationship of these patterns with seizures. The next question is, what is the evidence for secondary brain injury with these patterns? And again, there have been many small studies. The first, what I wanted to show you is just a summary of what we see in relation with generalized seizures and generalized status epilepticus. This diagram summarizes data from human as well as animal studies. And essentially, we know that when patients present with repeated generalized seizures, the body has a sympathetic response, which results in increase in cardiac output, increase in our blood pressure, increase in blood glucose to sort of compensate. And at the same time, the brain autoregulates, and the autoregulation allows the brain to maintain cerebral blood flow and maintain cerebral metabolism. However, beyond a certain threshold, usually if the seizures continue and are not controlled beyond 30 minutes or so, the compensatory mechanisms of the body are unable to keep up with the stress of the seizure. And we see cardiac output starts to decline, the body's metabolism starts to get affected, and at the same time, the brain compensatory mechanisms start to give out. And so we see a decrease in brain cerebral blood flow, as well as a decrease in brain oxygenation and an increase in brain metabolism. And so there are smaller studies that have tried to see whether a similar pattern can be found in association with other IIC patterns. This was a study that looked at PET correlates of IIC patterns. We know from studies of seizures and status epilepticus that patients who have generalized status epilepticus as well as non-convulsive status epilepticus, we see PET hypermetabolism, suggesting there's increased brain metabolism in association with these with seizures. Similarly, PET hypermetabolism was seen in association with generalized periodic discharges, as well as lateralized periodic discharges in this cohort of patients. Again, suggesting that these IIC patterns that are not clearly seizures but lie on the interictal continuum are associated with increased brain metabolism and potentially secondary brain injury. Another study that this came out of from the Columbia group looked at subarachnoid hemorrhage patients, and they looked at depth periodic discharges as well as brain tissue oxygenation. And what they found was that when periodic discharges reached a certain threshold, which was greater than 1.5 hertz, there was a significant drop in the brain tissue oxygenation. Again, suggesting that periodic discharges are associated with, with secondary brain injury as well as secondary brain metabolism. Finally, this is a study looking at traumatic brain injury patients, and they assessed periodic discharges and the association with brain metabolism as measured by brain glucose and brain lactate pyruvate ratio. And what they found was that in epochs where there was that periodic discharges were present, there was a drop in brain glucose and an increase in the brain lactate pyruvate ratio, again suggesting that there is increased brain metabolism and potentially secondary brain injury. Now, all these studies that I've gone through, of course, are small studies with small sample sizes. And so while we can say there is clearly an association between these patterns and secondary brain injury and increased metabolism, it is hard to draw a causal relationship between these patterns. We have yet to answer whether the patterns are directly causing the secondary brain injury, or whether it's an epiphenomenon, or whether it's a combination of the underlying etiology resulting in these patterns and then the patterns resulting in additionally brain injury and a subsequent vicious cycle. That is what a lot of the research that is ongoing right now is focusing on. So finally, shifting gears, we've talked about increased risk for seizures in association with these patterns. We've talked about an association with increased brain metabolism and secondary brain injury. That brings us to our final question of whether these patterns are associated with worse outcomes or not. And this diagram, again, summarizes some of the smaller studies that have looked at these patterns. And as with risk for seizures and secondary brain injury, generalized rhythmic delta activity is not significantly associated with worse outcomes. However, periodic discharges as well as lateralized rhythmic delta activity, they do have an association on the y-axis here is risk for mortality. And you can see that there is a stronger association with worse outcomes and higher risk for mortality. On the x-axis here is the association with seizures, which we've previously discussed, that these patterns do have a higher association with seizures as well. Looking again at some of the smaller studies that have assessed or tried to quantify the burden of these patterns and the association with outcomes, This was a study looking at the actual quantified burden of seizures and outcomes in subarachnoid hemorrhage patients. On the x-axis here is the number of hours spent in seizures, and on the y-axis is the probability of poor outcomes. And what they found was that the longer patients spent in seizures, the greater was the risk for poor outcomes in these patients. A similar study done in pediatric critically ill patients also looked at the association of the amount of time spent in seizures and the risk for poor outcomes. Again, on the x-axis here is the number of the hourly seizure burden, and on the y-axis here is the probability of poor neurologic outcome. And they found that as the seizure burden increases, the probability of poor outcome increases, and this relationship existed throughout different disease categories. So whether patients had acute brain injury or an acute structural injury, whether they came in with acute seizures and status epilepticus, or they had a primary systemic disease in the absence of brain injury, increasing seizure burden across all these disease subgroups was associated with worse outcomes. We looked at, we tried to assess the same thing, but not just with seizures. We also looked at other IAC patterns, periodic discharges, and rhythmic delta activity, and similarly found on the x-axis here is the maximum daily burden of these patterns as quantified by the ACNS nomenclature. And as the maximum daily burden increased, the probability of poor outcomes, and here we looked at 3-month functional outcomes, significantly increased. And this was after adjusting for their disease severity, after adjusting for their critical illness severity as well. The relationship held true. So there was an independent association with increasing burden of these patterns and the likelihood of poor outcomes. Finally, this is sort of the most recent work that we've done, which is looking at the association of these patterns and the actual burden and outcome across different disease subgroups. Acute brain injury, ABI, HIE is hypoxic ischemic encephalopathy, acute seizures and status epilepticus, and systemic illness. On the x-axis for each one of these is the peak burden. This is the maximum burden in any 12-hour period. And we essentially found that across all disease subgroups, as this peak burden increased, the probability of poor outcome, and here we assess their discharge, mortality, and functional outcome, that was worse with higher burden of these patterns. So, of course, if we think of these patterns being associated with higher risk for seizures, associated with increased risk for brain injury, and then finally associated with increased risk for poor outcomes, the next logical question is, well, should we be treating them, and that we should be treating them? Unfortunately, there currently are not large randomized trials that answer this question, and we don't have we have strong guidelines for management of acute seizures and status epilepticus, but we don't have clear guidelines for management of these electrographic or IIC patterns. And naturally, there are studies that show that many physicians frequently start anti-seizure treatments in response to these patterns. And in the absence of any treatment guidelines, what this results in is that there's significant practice variation across providers, across institutions. And this has also been documented in a recent study that looked at EEG and AED prescription practices across academic centers. And they found that while continuous EEG utilization patterns are similar, AED or anti-epileptic drug prescription patterns vary across physicians and institutions. And this is important because we do know that anti-epileptic drugs themselves have side effects. And so understanding whether treatment improves outcomes or not is the next big question that I think most researchers and most scientists in the field are trying to address. And what I thought would be a good, this is a good segue. While we don't have clear data on whether treatment improves outcomes or not, we do have several studies that have looked at whether EEG monitoring itself, and by default that would mean subsequent interventions, improve outcomes. And again, older data looked at smaller cohorts and smaller patient populations, and what they found was that continuous EEG monitoring resulted in longer hospital stays, more frequent anti-epileptic drug prescription, but didn't necessarily improve outcomes or mortality. But recently there have been 3 larger studies which I thought were important to review together. 2 studies have come out of the nationwide inpatient sample. And then most recently, there was a clinical trial that looked at continuous versus routine EEG. So I'll start here. This was a study that came out of the nationwide inpatient sample, which is a large national claims-based database. And they looked at patients that were critically ill and underwent continuous EEG monitoring. And what they found was that for critically ill patients that underwent continuous EEG monitoring, those patients had lower in-hospital mortality compared to patients who did not undergo continuous EEG monitoring. So the first panel in this figure, you can look at the full cohort where all patients who underwent continuous EEG monitoring were more likely to survive, or their in-hospital mortality was lower. This held true across the disease categories of subarachnoid hemorrhage and altered consciousness. But in patients with status epilepticus and seizures, this relationship did not hold true. While the authors found that continuous EEG monitoring was associated with lower in-hospital mortality, they did find that it was associated with increased cost hospitalization, and this relationship held true across disease diagnostic categories, and that these patients also had a longer length of stay. And so, there of course is this question about whether the decrease in hospital mortality, the benefits of that outweigh the risks of longer hospitalizations and length of stay. I think what is important also to know, of course, is functional outcomes, which were not assessed in this study, but were looked in a subsequent study that I will review in the next slide. So that's the largest data set that we have comparing continuous EEG monitoring versus no continuous EEG monitoring. There are studies that have then looked at continuous versus routine EEG monitoring. And again, this study came out of the nationwide inpatient sample, which showed that continuous EEG monitoring actually had a mortality benefit compared to routine EEG monitoring. This is just the trend for utilization, and continuous EEG utilization in this study increased by about 33% over a 5-year period, whereas routine EEG utilization did not, although it did increase, it didn't increase by the same amount. And what the authors found, as I mentioned before, was in-hospital mortality was significantly lower in those patients who underwent continuous EEG monitoring as compared to routine EEG monitoring. Total hospital charges as well as length of stay were not significantly different between the continuous EEG versus routine EEG group. And so the authors here concluded that continuous EEG, since it had a mortality benefit and did not seem to be associated with higher costs or length of stay compared to routine EEG monitoring, the recommendation was to consider continuous EEG monitoring whenever possible. The most recent study that tried to address this question was a pragmatic clinical trial that compared continuous versus routine EEG monitoring. Of note, this study, they actually excluded patients who presented with seizures or status epilepticus. So this study focused primarily on patients who presented with or had encephalopathy or altered mental status. And what the authors found in this study was that there was actually no difference, and they assessed 6-month mortality, so not just in hospital, but long-term. They found no difference in 6-month mortality when comparing patients who had continuous versus routine EEG. They also assessed functional outcomes, and looking at the modified Rankin score, those who got continuous EEG had a slighter improvement in their modified Rankin score, but then looking at their cerebral performance score, they were not significantly different across the two groups. The authors also did sensitivity analysis for these patients, looking at comparing continuous versus routine EEG across different ages, as well as across comparing baseline functional status across disease categories of encephalopathy and traumatic brain injury, and essentially found that in all their sensitivity analysis, there was no significant difference in 6-month mortality when comparing routine versus continuous EEG monitoring. The caveats of the study, of course, are that we can't generalize it to all patients since they did not look at seizures or status epilepticus patients. And other limitations of this study include that the time to EEG was variable. Certainly, getting EEG earlier can have different prognostic and therapeutic indications as opposed to starting EEG later. And so there were several limitations within this study as well. And pending larger studies, the recommendation from these authors was that it's reasonable to consider serial routine EEGs versus continuous EEG, particularly in lower resource settings. Again, with the caveat that they did not look at seizures or status epilepticus patients. So what does all of this mean to us? I mean, I think the challenge is that much of the data that we have, and especially these larger studies, the results are conflicting. They don't all look at the same population. They have not taken into consideration what the EEG findings themselves were, what treatments were administered. And so, the question is, with the ACNS guidelines and recommendations that we reviewed earlier, based on these studies, should we be revising them? Should we be considering different indications for continuous versus routine EEG? And I think given the limitations of the existing data, some of which we just talked about, the recommendations that the guidelines make, particularly around monitoring patients who have concern for non-convulsive seizures after generalized status epilepticus, or patients with acute brain injury who have altered mental status out of proportion. Some of these patients were not included in these studies. So in the randomized trial, seizure status epilepticus patients were excluded. And so I think given the limitations of all the existing data that we have out there, really taking into account what the underlying etiology is and what our question is can be applied to the ACNS guidelines. So for instance, if we have a patient who, it's a patient who came in with generalized seizures or status epilepticus, based on their recommendations, one should consider continuous EEG monitoring if they're not improving. And in this scenario, 24 hours of continuous EEG would be ideal, given the randomized trials have not included that. And then the larger database studies have their own limitations, where we don't have the duration of EEG that has been investigated or the exact EEG findings. On the other hand, if it's a patient with anoxic brain injury or post-cardiac arrest patients, where we're considering EEG more for the purposes of prognostication, where the ACNS recommendations themselves are a suggestion and not as strong a recommendation as for the other indications, one can consider using routine or serial routine EEGs as opposed to continuous EEG, given that there are studies that have shown that continuous versus routine EEG in these patients there's no significant difference in detection of EEG abnormalities and no significant difference in long-term outcomes, comparing routine versus continuous EEG. So just to summarize everything that we've discussed, IIC patterns, seizures are common in critically ill patients, but we've learned more and more that in addition to seizures, other periodic and rhythmic patterns that are now come to be known as IIC patterns are frequent, and that they are associated with a higher risk for seizures and a higher risk for poor outcomes. Whether we should be using continuous versus routine EEG for these patients and the duration of monitoring, the decision should really be take into account the ACNS recommendations, but also take into account the underlying etiology, the risk for seizures, and early EEG findings. So if a patient came in with generalized convulsive status epilepticus, then the risk for having non-convulsive seizures if they're not waking up is high, and I would consider continuous EEG for at least 24 hours. If a patient is encephalopathic and has metabolic derangements, and we can start EEG monitoring, and in the early EEG we see very high prevalence of epileptiform discharges. Again, their risk for seizures is high, and so I would consider longer monitoring or continuous EEG monitoring in those patients. And of course, the final question that really remains is whether treatment improves outcomes. And I think that's sort of what at least that's part of what I'm focused on studying. And I know that a lot of researchers and investigators who've been working on continuous EEG are trying to address the next question. One of the challenges randomized controlled trials are always are thought to be the ideal way to answer these questions. But because these critically ill patients are so clinically complex, and then their EEG findings, ICU patterns themselves are very dynamic, it's hard to design a randomized clinical trial and come up with the appropriate inclusion and exclusion criteria to be able to study the impact of treatments. And so looking at doing comparative effectiveness and larger database studies and pharmacoepidemiologic studies is another way to answer this question, and that's what a lot of investigators are doing. And I'm hopeful in the next few years we will begin to have answers to whether treatment improves outcomes or not. So that's all I'll have. I'll stop there and see, we can open it up to questions.
Well, thank you. That was very good, very enlightening, and I think that the comments that we're getting so far is that it's been really well positioned as far as understanding outcomes. It brings up a question right now when we talk about outcomes: what outcomes should be reviewed or should be tracked? Because mortality, of course, is the key one, but what other outcomes are there from a functional standpoint?
No, and I think that's a great question. So, a lot of studies have looked at mortality. That's easy to assess. But I think outside of that, functional outcomes, so some of the studies, I didn't go into detail, but functional outcomes that they have looked at include the modified Rankin score, which is a physical functional outcome. Then cognitive outcomes are important. And I think health-related quality of life outcomes, particularly for these patients who end up being discharged on multiple AEDs, have AED-related adverse effects. We all see patients in the epilepsy clinic who, we've all heard from our patients, I'd rather have a seizure than have the adverse effects that I'm experiencing. So I think as we design larger studies as well as randomized studies, in addition to mortality, we should be looking at functional outcomes. We should be looking at cognitive outcomes in these patients. We should be looking at health-related quality of life outcomes. And so patient-centric outcomes are important.
Okay. There is a question here regarding the Ichthyological Continuum and the patterns with increased risk of seizures. Does it increase the risk for non-convulsive seizures and clinical seizure, or just non-convulsive seizures only?
Yeah, so there was, they looked, there's more data on non-convulsive seizures. So there's a higher risk of identifying non-convulsive electrographic seizures in these patients under continuous EEG monitoring.
All right, thank you. And they're asking for your opinion on the use of continuous EEG monitoring in patients that are going through the cooling phase in therapeutic hypothermia treatment.
So I think that is, again, there's the indication for continuous EEG in that scenario sort of two, well, there's multi-pronged. One, of course, is when they're going through the cooling phase, it can help in assessing depth of sedation. And when they're in the cooling phase, they're also on paralytics. And so, we know that patients with anoxic brain injury can be at high risk for seizures, and, being on paralytics, we may not be able to capture that. So one is assessing that indication. Typically, when they're in the cooling phase, they're so sedated and on high levels of anesthetics. Sometimes it may not be, the propofol itself may be resulting in suppression of the EEG background. And so I think in the actual cooling phase itself, the real benefit is to assess depth of sedation and detect seizures in those patients that are heavily paralyzed. I think the real benefit that comes in as cooling is weaned and sedatives are weaned, and we start to see what the EEG background shows. And that's really the highest risk period for these patients, where seizures may show up that may need to be treated, and we start to get a better sense of what their background looks like that can help in prognosis as well.
Very good, very good. There's a question here about the availability of any studies that were done looking at continuous monitoring versus serial EEG studies, routine EEGs. especially related to things like skin breakdown or missed seizures, missed events?
Sorry, so Doc, what was the question? The risk for skin breakdown and then the risk for missed events?
Missed events, whether, if you're using intermittent versus continuous.
Yeah. So I think that, so first, just with regards to skin breakdown, I think that we, the longer you monitor, of course, the greater is the risk for skin breakdown. But I think, in general, with good skin care and good nursing care and proper application, 24 hours of EEG or 48 hours of EEG doesn't result in the skin breakdown that we're concerned about. And if we're anticipating longer monitoring than that, then one could consider, often we do EEG holidays or EEG break, depending on what the EEG is showing. And I think the question around, the concern of missing seizures, again, it really depends on the risk of seizures in the patient and what the EEG has shown thus far. So if you have someone who has been on continuous EEG monitoring and their EEG has been benign or has not shown seizures or has not shown periodic discharges, the longer they go on like that, the risk for seeing a seizure significantly decreases. And so I think the risk for missing seizures starts to decrease as time goes on. And if there's a concern for skin breakdown, what one could do is, for the first 24 hours, do continuous EEG. You found nothing, then you can give a break and then do serial EEGs or shorter EEGs, given the risk. As I said, there's data that shows that, if you've not had, the risk for seizures significantly drops at 16 hours if you haven't had seizures up until then. And then beyond 72 hours, the risk for seizure, if you haven't had anything up until that point, is negligible, is significantly low. Studies have shown that. So I think you can sort of use those time frames and do continuous EEG monitoring early on, and then switch over to serial EEG monitoring as you go beyond the risk period.
Very good. That's all the questions we have now. I want to thank you again. And there will be an email going out with a link to the replay of this. There was a lot of information in here, and some of it certainly will merit review. Thank you again, and we'll see you next time. Good day.